artificial urinary sphincter placement, practice essentials. A biological urinary sphincter prevents urinary flow via mucosal coaptation, compression, and pressure transmission. An artificial urinary sphincter, AUS, mimics the biological urinary sphincter by providing a competent bladder outlet during urinary storage and an open unobstructed outlet to permit voluntary voiding. An artificial urinary sphincter is the only device that closely simulates the function of a biological urinary sphincter. Decades of advances in mechanical design, applications of new technology, and lessons learned from clinical experience have inspired notable improvements. Novel and ingenious in technical design, the AMS 800, American Medical Systems, Minnetonka, Minn, device has restored the quality of life to thousands of patients plagued by severe stress urinary incontinence. The AMS 800 prosthesis is the most effective, reliable, and durable surgical treatment for men with post-prostatectomy urinary incontinence, achieving social continence rates of 75 to 95%. Problem: an artificial urinary sphincter is reserved for treatment of complex or severe stress urinary incontinence. Type 3 stress urinary incontinence, or intrinsic sphincteric dysfunction, is the inability of the urethra to maintain effective resting urethral closure pressure sufficient to keep the patient clinically dry at rest and during periods of reasonable physical activity. Etiology: patients with intrinsic sphincteric dysfunction include men who have undergone radical retropubic prostatectomy, including laparoscopic or robotic-assisted radical prostatectomy, radical perineal prostatectomy, or transurethral resection of the prostate, TURP, patients with previous pelvic trauma or a history of pelvic radiation, and women in whom anti-incontinence procedures have failed. Patients with spinal cord injuries, myelomeningocele, or other causes of neurogenic bladder may also have intrinsic sphincter dysfunction. Pathophysiology: the normal voiding cycle requires that the urinary bladder and the sphincter work as a coordinated unit. The urinary bladder has two functions: it relaxes to store urine, storage or filling phase, and it contracts to eliminate urine, voiding phase. During urinary storage, the bladder is placid and acts as a low-pressure reservoir. During voiding, the bladder actively contracts to act as a pump. The urinary sphincter has two functions: it contracts to store urine and it relaxes to eliminate urine. During urinary storage, the urinary sphincter remains closed to prevent urine loss. At the beginning of the voiding phase, the urinary sphincter opens to allow unobstructed urination. Urinary incontinence results from dysfunction of the bladder, the sphincter, or a combination of both. Bladder overactivity causes urinary frequency, urgency, and urgency incontinence. Bladder underactivity causes urinary retention. Sphincteric overactivity causes urinary retention. An inadequate or hypoactive sphincter results in stress incontinence. A combination of bladder overactivity and sphincteric underactivity results in mixed urinary incontinence, stress and urge. Intrinsic sphincteric dysfunction is a complex form of stress incontinence whereby the urethra always remains open. Risk factors for intrinsic sphincteric dysfunction include: 1. Radical prostatectomy. 2. TURP, previous bladder neck surgeries. 3. Pelvic radiation, pelvic trauma. 4. Neurologic disorders. A common denominator of intrinsic sphincteric dysfunction is low urethral resistance at rest and during periods of physical activity. Whenever the intravesical pressure becomes greater than the urethral resistance, stress incontinence ensues. A reliable method of restoring continence is by artificially increasing the urethral resistance. Many approaches to this problem have been devised over the years. The main criterion for implanting an artificial urinary sphincter is a relatively normal detrusor in a setting of intrinsic sphincteric dysfunction. Presentation: patients with intrinsic sphincteric dysfunction present with the classic history of stress urinary incontinence. They experience predictable loss of urine whenever the intravesical pressure exceeds that of the urethral pressure, e.g., when coughing, laughing, sneezing, sitting down, or performing the Valsalva maneuver. Often, Patients with intrinsic sphincteric dysfunction complain of involuntary urine loss when changing their body position, e.g., when rising from a sitting position. Women with intrinsic sphincteric dysfunction experience more urine loss and require thicker pads than women with incontinence due to urethral hypermobility. Intrinsic sphincteric dysfunction can often be distinguished from other causes of incontinence by patient history and physical examination. In patients with pure intrinsic sphincteric dysfunction, symptoms of urinary frequency, urgency, and nocturia are typically absent. However, when such storage symptoms are present, coexisting overactive bladder should be suspected. As such, patients should undergo preoperative endoscopic and urodynamic evaluations. Indications. Candidates for artificial urinary sphincter include patients with bothersome stress urinary incontinence due to ISD. Indications in men and women of all ages include the following: postprostatectomy incontinence, which is the most common indication for placement of an artificial urinary sphincter. Placement of the artificial urinary sphincter should be deferred for at least 6 months after prostatectomy. Many physicians defer placement for up to 1 year because patients often regain some or all continence during this time. Intrinsic sphincteric dysfunction following pelvic fracture, spinal cord injury, urethral reconstruction, or multiple previous failed anti-incontinence procedures. Neurogenic bladder with associated sphincter or bladder neck incompetence. Although not commonly done in the United States, in Europe the artificial urinary sphincter has been used in women with stress incontinence due to intrinsic sphincter deficiency. This is done through an abdominal, not perineal, or vaginal, approach. Long-term data now support this indication, with low rates of mechanical problems and high success rate. Careful patient selection is arguably the most important factor in predicting success of the artificial urinary sphincter, and the following should be considered. Female patients and children require bladder neck placement of the sphincter and must be motivated to perform and capable of performing clean intermittent catheterization, as this may be required because of postoperative urinary retention. All patients must have sufficient sophistication and hand functionality, as well as manipulative strength, to operate the pump and its associated lockout mechanism. All patients must understand the potential complications of the operation and the possibility of future surgical interventions for tissue atrophy, cuff erosion, cuff migration, mechanical failure, and device infection. The long-term reoperation rate is about 20%. Essential characteristics of an ideal patient include highly motivated personality, good manual dexterity, relatively normal detrusor, absence of urinary tract infection, UTI, failure of alternative means of incontinence control, and realistic expectations. Although some patients may expect to remain completely dry, a realistic and satisfactory goal is achieving social continence, which is generally defined as requiring no more than 1 incontinence pad a day. Careful patient selection can greatly reduce the likelihood of a disappointed patient and surgeon. A study by Gelman et al. Evaluated the impact of patient age on device outcomes among patients undergoing primary artificial urinary sphincter. The study found that although overall artificial urinary sphincter device survival is similar, patients aged greater than 80 years are more likely to experience erosion or infection compared with younger patients. The authors added that despite this, the overall device failure rate is low, and artificial urinary sphincter might be considered for appropriately selected and counseled octogenarians. Relevant anatomy: the urethra is composed of an inner epithelial lining, a spongy submucosa with rich vascular plexus, a middle smooth muscle layer, and an outer layer of fibroelastic connective tissue. The spongy submucosa is responsible for providing urethral occlusive pressure. The ability of the urethral mucosa to cope to generate an adequate urethral closing pressure is an important continence mechanism. Urethral smooth muscle and fibroelastic connective tissues serve to circumferentially augment the occlusive pressure generated by the submucosa. The urinary sphincter is composed of an internal sphincter and an external sphincter. In females, the internal sphincter is composed of the bladder neck and proximal urethra. In males, the internal sphincter is composed of the bladder neck and prostate. Both males and females possess an external sphincter known as the rhabdosphincter. The rhabdosphincter is omega-shaped and is composed of two types of striated muscle fibers: fast twitch and slow twitch. Contraction of fast twitch fibers causes sudden stopping of the urinary stream. This is known as the voluntary guarding reflex. These fibers are responsible for allowing Kegel exercises. Slow twitch fibers maintain the constant tonus of the external sphincter, which is important in daily physical activities. This is known as the involuntary guarding reflex. Contraindications. Contraindications for placement of an artificial urinary sphincter include the following: UTI. All candidates for an artificial urinary sphincter should be screened for UTI preoperatively. Recurrent urethral strictures or diverticula, small bladder capacity or poor compliance. However, some patients with this contraindication are candidates for artificial urinary sphincter with concomitant or preoperative augmentation cystoplasty. There are also many relative contraindications, such as the following: grade 2 or higher vesicoureteral reflux should be corrected before artificial urinary sphincter placement. Recurrent disease, e.g., stone disease, bladder, or ureteral tumors, that requires retrograde endoscopic instrumentation is a relative contraindication. Such instrumentation can predispose to cuff erosion in patients with an artificial urinary sphincter. Bladder neck contractures, a not uncommon complication of prostate surgery, should be treated first, and cystoscopy or retrograde urethroplasty should be performed at least 3 months afterward to ensure continued patency of the bladder neck before proceeding with artificial urinary sphincter placement. Uncontrolled detrusor overactivity. In patients with significant mixed incontinence, controversy exists about which should be treated first, the bladder or the outlet. One review of post-prostatectomy patients treated with AUS showed that 29% of patients with preoperative OAB had resolution of their OAB. On the other hand, the de novo OAB rate was 23%. All patients were treated with anticholinergics. Artificial urinary sphincter placement workup. Laboratory studies. Urinalysis and urine culture. The possibility of UTI should be ruled out before implanting an artificial urinary sphincter. The presence of a UTI is a contraindication to artificial urinary sphincter placement. Serum white blood cell, WBC, count. Systemic leukocytosis should be treated before surgery. Serum creatinine. The patient should have relatively normal and stable renal function before AMS 800 artificial urinary sphincter placement. Imaging studies, voiding cystourethroplasty. This test is optional but can be used to assess bladder neck and urethral function, i.e., internal, external sphincter, during the filling and voiding phases. Voiding cystourethroplasty, VCUG, allows radiographic observation of an incompetent bladder neck and coincident leakage during Valsalva maneuvers. VCUG is performed most often at the time of videourodynamics. Grade 2 or higher vesicoureteral reflux on VCUG should be corrected before placement of the artificial urinary sphincter because the sphincter can exacerbate reflux. Other tests. 1. Voiding diary. A voiding diary is a daily record of a patient's bladder activity. The diary is an objective documentation of a patient's voiding pattern, incontinent episodes, and any inciting events associated with urinary incontinence. Although not critical, a properly logged voiding diary can provide stronger documentation of the degree of incontinence than the standard question regarding number of pads per day used by the patient. Keeping track of fluid intake and urine output in the diary can give further insight into the patient's incontinence and identify patients who can improve their incontinence with less invasive interventions, such as timed voiding. It can also help identify patients with associated problems such as polyuria. Physical examination. All patients with incontinence should undergo a complete physical examination. Women with incontinence must undergo a full pelvic examination to note pelvic floor weakness, e.g., cystocele, rectocele, enterocele, urethral hypermobility, urethral or vaginal lesions, or uterine or adnexal masses. Pad test. Patients with classic intrinsic sphincteric dysfunction present to the office with a diaper or a pad in place. An adult male with a damp or wet pad inside his underwear has urinary incontinence unless proven otherwise. It is important to ask patients not only how many pads they use in a day but also how wet those pads get, from lightly dampened to soaked. Standing cough stress test. The patient stands upright with feet shoulder width apart. Place a large towel under the patient's feet or a small trash can between the patient's feet to catch the flow of urine. Instruct the patient to perform the Valsalva maneuver and to cough in gradients, i.e., mild, moderate, severe. Observable urine leakage in this position constitutes a positive test result. If the bladder is empty at the time of the Valsalva maneuver or cough, the test result is falsely negative. An excellent alternative is to leave the bladder full following cystoscopy and have the patient stand over a towel. Ask the patient to perform the Valsalva maneuver, and watch for a leak. Following this task, see if the patient can maintain continence while walking to the restroom. Urodynamic studies. Urodynamics is a means of evaluating the bladder capacity, compliance, abdominal leak point pressure, presence of phasic contractions, and pressure flow relationship between the bladder and the urethra. Simple urodynamics involves non-invasive uroflow, post-void residual, PVR, urine volume, and single-channel cystometrography, CMG. A single-channel CMG, simple CMG, is used to assess the first sensation of filling, fullness, and urge. Bladder compliance and the presence of uninhibited detrusor contractions, e.g., phasic contractions, can be noted during this filling CMG. A filling CMG is used to assess the bladder capacity, compliance, and presence of phasic contractions. Most commonly, liquid filling medium is used. An average adult bladder holds approximately 450 to 500 ml of urine. During the test, provocative maneuvers, such as coughing, hand washing, sitting on the commode for 1 full minute, and heel jouncing, may help unveil bladder instability. Insert a catheter, connected to a special computer, into the bladder for a single-channel CMG. Information recorded by the computer is interpreted. Eyeball cystometry does not require special computers. Perform bedside cystometry by inserting a catheter into the bladder, hanging the irrigant bag at a predetermined height, e.g., 100 cm water, and observing the fluctuation of the meniscus within the water chamber during uninhibited detrusor contractions. Eyeball cystometry can also be performed with a flexible cystoscope being used as the connection tubing, allowing simultaneous cystoscopy. Multichannel urodynamic studies are more complex than simple urodynamic studies and can be used to obtain additional information, including a non-invasive uroflow, PVR, filling CMG, abdominal or Valsalva leak point pressure, ALPP or VLPP, voiding CMG, pressure flow study, and electromyography, EMG. Water is the fluid medium used for multichannel urodynamics. A voiding CMG, pressure flow study, simultaneously records the voiding detrusor pressure and the rate of urinary flow. This is the only test that can be used to assess bladder contractility and the extent of a bladder outlet obstruction. Pressure flow studies can be combined with a voiding CMG and videourodynamic study for complicated cases of incontinence. Note that most adult men normally void with detrusor pressures, PTET max, of 40 to 80 cm water. However, pressures of 20 to 30 cm water or lower are considered to be within the reference range if uroflow, Qmax, is within the reference range or high. Abdominal, Valsalva, leak point pressure, ALPP, measurements allow clinicians to classify stress urinary incontinence into type I, type 2, and type 3, or type 2 and 3 in combination. ALPP of 0 to 60 cm water is classified as type 3 stress urinary incontinence, i.e., intrinsic sphincteric dysfunction. In short, the outlet is so weak that even low pressures can overcome the resistance and produce incontinence. ALPP of 60 to 90 cm water is classified as type 2/3 stress urinary incontinence, i.e., combination of urethral hypermobility and intrinsic sphincteric dysfunction. ALPP of 90 to 120 cm water is classified as type 2 stress urinary incontinence, i.e., urethral hypermobility. ALPP greater than 120 cm water is classified as type I stress urinary incontinence. ALPP should be measured when the bladder is half full, e.g., 250 ml, and both the Valsalva and coughing maneuvers should be performed. Initially, instruct the patient to bear down in gradients, i.e., mild, moderate, severe, and then note the ALPP as the lowest intravesical pressure, PVES, at which leakage is observed. If Valsalva maneuvers fail to produce the desired response, instruct the patient to cough in gradients, i.e., mild, moderate, severe, to obtain the ALPP. The lowest intravesical pressure, PVES, at which leakage is observed is the ALPP. The ALPP obtained with the Valsalva maneuver is more accurate than the cough-induced ALPP. However, both techniques should be used if Valsalva maneuvers fail to manifest stress urinary incontinence. Alternatively, both Valsalva and cough-induced ALPP may be repeated by increasing the bladder volume in 100 ml gradients. Increasing the bladder volume reportedly increases the sensitivity of detecting ALPP. Obtaining ALPP in male stress incontinence, ISD, is optional because men with type 3 stress incontinence, by definition, have ALPP less than 60 cm water. The most sophisticated study is videourodynamics, which is the leading standard in the evaluation of a patient with incontinence. In this study, the following are obtained: non-invasive uroflow, PVR, filling CMG, ALPP, voiding CMG, pressure flow, EMG, static cystography, and VCUG. The fluid medium used for videourodynamics is radiographic contrast. Performing urodynamic studies. Instruct the patient to arrive at the urodynamic laboratory with a relatively full bladder. Note that patients with ISD have a low volume or empty bladder because of continuous incontinence. Perform a non-invasive uroflow and PVR. Some physicians perform cystoscopy at the same time as urodynamics, although the two can be done separately. Place a urodynamic urethral catheter, rectal tube, and EMG electrodes. Rotate the patient to a standing or sitting position and equalize transducers. Commence bladder filling using room temperature water or contrast, Conray. Cold water may evoke false positive detrusor contractions, phasic contractions. Fill the bladder at a medium rate, e.g., 50 ml/min. Assess the first sensation of filling, fullness, and urge. Note bladder compliance and mark the presence of uninhibited detrusor contractions. When the bladder fills to 250 ml, measure the ALPP. Instruct the patient to perform the Valsalva maneuver in gradients, i.e., mild, moderate, severe, followed by cough, i.e., mild, moderate, severe. Observe the urine leakage fluoroscopically and by direct inspection. Following the ALPP measurements, finish the filling CMG to completion. When the patient has a strong desire to void, perform a voiding CMG, pressure flow study. At this point, note urodynamic parameters, such as maximal flow rate, Qmax, and detrusor pressure at maximal flow rate, DET-Qmax. During the voiding CMG, note the activity of the EMG electrodes and VCUG for possible detrusor sphincter dyssynergia, DSD. The presence of DSD is confirmed by increases in EMG activity during detrusor contraction or closure of the external sphincter on VCUG during voiding. After the patient voids to completion, the videourodynamic study is complete. The patient is informed about the findings on urodynamic studies and is sent home. Uroflow rate. The uroflow rate is a screening test used mainly to evaluate bladder outlet obstruction. The uroflow rate is the volume of urine voided per unit of time. Maximal flow rate, Qmax, greater than 15 ml/s may be considered within the reference range. Low uroflow rates, 15 ml/s, may reflect urethral obstruction, a weak detrusor, or both. This test alone cannot be used to distinguish between obstruction and a poorly functioning detrusor. Patients with intrinsic sphincteric dysfunction demonstrate uroflow rates within the reference range. A voided volume of 150 ml is a generally accepted minimum for accurate uroflowmetry, and variations of 2 to 4 ml/s in a single patient are common, so more than one measurement may be required. A maximum flow rate of less than 15 ml/s is usually considered abnormal but must be considered within the context of the patient's clinical presentation. Post-void residual urine volume. This measurement is a part of the basic evaluation for urinary incontinence. Healthy men usually have a PVR urine volume of less than 100 ml. If the PVR volume is high, the bladder may be atonic or the bladder outlet may be obstructed. Both of these conditions cause urinary retention and overflow incontinence. Patients with intrinsic sphincteric dysfunction have minimal PVR urine volume. Electromyography. EMG helps ascertain the presence of coordinated or uncoordinated voiding. Failure of urethral relaxation during a bladder contraction results in uncoordinated voiding, i.e., DSD. EMG is not necessary for evaluation of men who are incontinent after prostatectomy. However, EMG is used in combination with multichannel urodynamic studies and is important in the evaluation of neurogenic bladders. Cystoscopy. Cystoscopy is optional in female patients. However, it may uncover bladder lesions, e.g., stitch in the bladder, bladder cancer, bladder stone, vesicovaginal fistula, that, although uncommon, would remain undiagnosed based on urodynamics findings alone. The bladder can be left full following cystoscopy to perform the standing cough test. In male urinary incontinence, cystoscopy should be performed more routinely, because a visual inspection of the urethra helps establish the presence of urethral stricture or diverticulum, bladder neck contracture or anastomotic stricture, or gross evidence of poor urethral coaptation and closure. It is important to examine the external sphincter both with and without the flow of irrigant to ascertain the degree of sphincter incompetence. In general, cystoscopy is also indicated for patients reporting persistent dysuria, storage symptoms, or hematuria. Obvious causes of bladder overactivity, including cystitis, stone, and tumor, can be easily diagnosed. Patients with a history of pelvic radiation may have findings of radiation cystitis on cystoscopy. This information is important in determining the etiology of the incontinence and may influence treatment decisions. In the absence of videourodynamics, the clinician may obtain adequate information regarding male incontinence from 1. Non-invasive uroflow and PVR. 2. Simple cystometry in combination with cystoscopy. Medical therapy. No known reliable medical therapy exists for post-prostatectomy male stress incontinence. Alpha agonists have not been demonstrated to be helpful in correcting male intrinsic sphincteric dysfunction. Periurethral bulking agents, including collagen injections, have a long history of use in incontinence. They have been effective in improving stress incontinence symptoms, but problems with agent migration or absorption have limited their long-term efficacy. Overall improvement varies from 35 to 70%, and multiple injections are often required. Nonetheless, collagen injections present a less invasive alternative for patients who are wary of an implanted device or are poor candidates for the artificial urinary sphincter. For women with intrinsic sphincteric dysfunction, estrogen therapy, alpha agonists, or both have provided some improvement in symptoms. Periurethral collagen injections are most effective for women with intrinsic sphincteric dysfunction, producing cure rates that last as long as 1 or 2 years. Although the efficacy of periurethral injection therapy is better in women than in men, the treatment does not produce lasting cure, for the same reasons. Duloxetine is a serotonin and norepinephrine reuptake inhibitor that is indicated for depression and has been shown to increase resting urethral pressure and may, therefore, decrease stress incontinence in women. Clinical trials for use of duloxetine in post-prostatectomy patients are currently in progress. Duloxetine is not yet approved by the U.S. Food and Drug Administration for treatment of incontinence in men or women. Other non-invasive options include Kegel exercises, which should be taught to all women with genuine stress incontinence and men with post-prostatectomy incontinence. In addition, for men with incontinence, there are external continence clamps that are applied to the penile urethra. However, although these clamps are non-invasive and easily discontinued, they demonstrate limited efficacy and are uncomfortable for many men to wear. In short, all non-invasive interventions for stress incontinence caused by intrinsic sphincteric dysfunction are less effective than surgical interventions. Surgical therapy. Male suburethral slings. Invance male sling. In 2000, American Medical Systems, AMS, launched the Invance male suburethral sling, a surgical option for men with intrinsic sphincteric dysfunction, which usually occurs after radical or transurethral prostatectomy. The male sling is not as effective as the artificial urinary sphincter and is therefore indicated only for patients with mild to moderate stress incontinence due to intrinsic sphincteric dysfunction and patients with significant incontinence who are not candidates for the artificial urinary sphincter. Patients who continue to have significant incontinence after placement of the suburethral sling may still be candidates for an artificial urinary sphincter, i.e., prior placement of a sling is not a contraindication to placement of the artificial urinary sphincter. Advance male sling. In 2004, AMS launched the Advance male suburethral sling, which is a transobturator suburethral sling placed perineally. The Advance sling is indicated for men with mild to moderate stress incontinence, as is the Invance male sling. In establishing candidacy for the Advance sling, demonstration of residual sphincter function is necessary preoperatively. Urethroscopy can be used to evaluate function. In this study, the patient is asked to voluntarily coapt his sphincter under direct vision. Alternatively, the ability for the patient to voluntarily stop and start their urinary stream demonstrates residual sphincter function. The Advance sling has shown excellent short-term results. As with the Invance, patients in whom Advance sling placement fails are still candidates for the artificial urinary sphincter. Coloplast Virtue. Coloplast launched the Virtue male sling in summer 2009. Also placed through a perineal approach, the Virtue has 4 arms, 2 of which are past prepubic, and 2 through the obturator foramen. It has been described as a hybrid device, offering urethral mobilization through the transobturator arms, and urethral compression through the prepubic arms. The AMS 800 device. The AMS 800 artificial urinary sphincter is the most commonly used device and is the criterion standard for the treatment of incontinence caused by intrinsic sphincteric dysfunction. It is composed of a pressure-regulating balloon, an inflatable cuff, and a control pump, see image below. The balloon has a dual function as a pressure regulator and a fluid reservoir. Photo 0. Balloon reservoirs come in 5 preset pressures: 41-50, 51-60, 61-70, 71-80, and 81-90 cm water. The lowest pressure required to close the urethra is used. Balloon reservoirs are typically placed in the lower abdomen. For uncomplicated bulbar urethral cuffs, the most commonly chosen balloon reservoirs are the ones with preset pressures of 51-60 and 61-70 cm water. For bladder neck cuffs, the balloon reservoir with pressures of 71-80 cm water is chosen because higher pressures are necessary to occlude the bladder neck. Patients with prior radiation or surgical changes that present a higher risk of erosion may benefit from a 51-60 cm water reservoir. In addition to a lower pressure reservoir, some advocate transcorporal cuff placement in patients with a history of radiation therapy. The inflatable cuff has a variable length that compresses the urethra or the bladder neck circumferentially. Cuff sizes range from 3.5 to 11 cm, in 0.5 cm increments. The cuff is placed around the bulbar urethra in adult males. For women and children, the bladder neck is the only site that should be used. The cuff size is based on the circumference of the bladder neck or the bulbar urethra. A properly sized cuff for the bulbar urethra ranges from 4.5 to 5.5 centimeters in length. Most commonly, a 4.0 centimeters cuff is chosen for adult males. For the bladder neck, a 6 to 8 centimeters cuff is selected in women. The control pump contains unidirectional valves, a delayed fill resistor, a locking mechanism, and a deflate pump. The control pump is small and easily concealed within a subcutaneous or dartus pouch in the scrotum or the labia. The delayed fill resistor is responsible for automatic cuff refilling. The cuff inflation takes 3 to 5 minutes, although bladder emptying takes less time. A unique feature of this model is the locking mechanism that can keep the cuff deflated for a prolonged period. The locking mechanism is a small button located on the side of the control pump. Mechanics of the AMS 800. The AMS 800 artificial urinary sphincter works on the basis of hydraulic mechanics. The isotonic fluid within the sphincter is transferred from the reservoir to the cuff and vice versa in a unidirectional fashion. When the sphincter is first activated, unlocked, the fluid from the reservoir travels down the pressure gradient to the cuff. The cuff gradually inflates to effectively close the urethra. The inflated cuff causes urine to be stored in the bladder and prevents urine loss. The device works in a semi-automatic fashion, with the cuff remaining closed at all times except when the patient opens the cuff for voiding. To void, the patient must open the artificial sphincter. The patient manually squeezes the control pump that is located in the scrotum or the labia. When the control pump is squeezed, the fluid in the control pump is sent up to the balloon reservoir. The control pump then automatically re-expands. As it re-expands, it pulls the fluid out from the cuff, which causes the sphincter cuff to deflate. The patient repeats this maneuver 3 to 4 times until the pump remains flat, which indicates that the cuff is completely empty. At this point, the urine flows freely from the bladder. Urination continues until the bladder is empty. After 3 to 5 minutes, the fluid from the balloon reservoir automatically flows through a delayed fill resistor within the pump and down back to the cuff. When the cuff rain flats, the urethra becomes effectively closed and the patient becomes dry. The locking mechanism, button on the side of the control pump, allows the physician to lock the cuff in an open or closed position. Typically, the AMS 800 device is left locked, deactivated, in an open position at the time of surgical implantation to allow for adequate tissue healing and is unlocked in the physician's office 6 to 8 weeks after operation. If the patient inadvertently locks the button when the cuff is closed, urinary retention occurs. Conversely, if the button is locked when the cuff is open, persistent incontinence occurs. Patients should be instructed on the locking mechanism to understand and be able to respond to these problems. Limitations of the AMS 800. Although the AMS 800 artificial urinary sphincter is an extremely reliable prosthesis that is easy to place and the patient satisfaction rate is high after successful implantation, certain limitations exist with this device despite advances in mechanical design. Mechanical malfunctions, i.e., cuff leak, defective pump, and surgical problems, i.e., pump migration, cuff migration, improper cuff size, require reoperation and sphincter revision. Urinary incontinence may arise from improper usage, fluid leakage, pressure atrophy, or cuff erosion. Urinary retention may occur as a result of particle obstruction or a tube kink in the system. Silicone composition. The AMS 800 is composed of permeable silicone elastomer. Although relatively inert and resistant to body fluids, silicone deteriorates and loses tensile strength over time. Because the cuff is permeable, fluid escapes over time, with the resultant decrease in closing cuff pressure. The constant rubbing together of the two silicone components can lead to thinning of the silicone elastomer and exacerbate fluid leakage. The hydraulic system, the balloon, cuff, pump, and connecting tubings are filled with isoosmotic solution. Either isotonic sodium chloride solution or radiocontrast is used. The tonicity of the contrast is approximately 290 to 310 mosm/L, which is similar to that of human intracellular and extracellular fluid. The use of hypoosmolar or hyperosmolar fluid causes sphincter malfunction from osmotic fluid shifts. Pressure regulating balloon. The fluid volume of the pressure regulating balloon regulates the cuff pressure. A typical balloon reservoir holds 20 to 22 ml of isoosmotic fluid. The pressure-volume relationship of the AMS 800 device is very narrow and sigmoid curve-shaped. Small volume changes, e.g., 2 ml, decrease the pressure characteristics. When the volume decreases to below 14 ml, the pressure decrease is precipitous. A common cause of post-activation incontinence is fluid loss from the pressure-regulating balloon. The patient notices that the number of squeezes to deactivate the pump has decreased or the pump does not refill and remains flat. The incidence of balloon leak responsible for sphincter malfunction has been reported to be as high as 13% in some series. Inflatable cuff. A common problem leading to delayed or persistent incontinence is fluid loss caused by a wear defect in the cuff. The most common site of fluid leak is the lower surface of the cuff. In 1983, the inner surface of the cuff was reinforced with a layer of fluorosilicone gel to prevent friction between two leaflets. With this modification, the cuff leak rate decreased from 56% to 1.3%. Connecting tubing. A short tube length may disrupt connecting junctions, causing a fluid leak or pulling up the control pump into the inguinal area, making device manipulation difficult. Excess tube length may lead to kinks, obstructing the system and causing urinary retention. Kinks are rare after 3 months of device implantation. In the past, tube kinks were the most common mechanical cause for surgical revision. With the advent of reinforced kink-proof tubing, no mechanical failures have been reported. However, tube kinks still may occur from tailoring connecting tubes to an improper length during the implant procedure. Control pump. The control pump is cosmetically appealing because of its small size. Its small size can be a handicap, however, because some patients may have difficulty manipulating the pump. Labial or scrotal hematomas may displace the pump into an unfamiliar location. The pump may rotate upon itself and become kinked. Migration of the pump into the inguinal region may cause failure to deflate the cuff. Locking mechanism. A major technological advancement of the AMS 800 is its locking mechanism. The disadvantage is that activating and deactivating the cuff using the locking mechanism is not always easy. The locking mechanism lacks a tactile feedback mechanism, making it difficult to tell if locking has occurred. Before locking the cuff, one must be sure that some fluid remains in the pump chamber. If the pump chamber is totally flat and empty, unlocking, activating the cuff in the standard fashion is impossible. If this occurs, squeezing the sides of the locking button, located immediately above the pump chamber, allows the fluid to return to the pump chamber by circumventing the delayed fill resistor. Intraoperative details. Once the patient is in the operating room, the abdomen and genitalia are shaved. Following the shave, the area is scrubbed for 10 to 15 minutes. For bulbar urethra cuff placement, the patient is placed in the dorsal lithotomy position. The patient is draped for both a perineal and an abdominal incision. The use of barrier drapes reduces the risk of contamination with skin flora. A plastic draped Mayo stand is used as a station for handling and filling of prosthetic components. The surgical setup should include a broad-spectrum antibiotic solution for irrigation. The antibiotic solution and the filling solution should be kept separate from each other. Components should not have contact with paper or cloth drapes. Submerge the filled components in a storage basin containing sterile sodium chloride solution until they are ready for implantation. Silicone components actively attract dust and lint. Glove powder that enters the tubing may block the pump valves. Surgeons should wash their gloves before making the tubing connections. The operative technique of placing the urethral cuff is described below. The patient is placed in the dorsolithotomy position. A perineal incision has been made below the scrotum. The Colles fascia is being dissected off. The perineal incision is being closed. The Colles fascia is closed. The skin is closed next. The balloon reservoir has been placed into the subrectus space, and the control pump has been inserted into the right hemiscrotum because the patient is right-handed. The cuff, pump, and reservoir are all connected. Balloon reservoir placement, make a suprapubic incision. A midline or transverse incision is made. Divide the rectus fascia. Spread the linea alba to reach the prevesical space. Use blunt dissection to create a space for the balloon. Fill the balloon with 22 ml isoosmotic filling solution, aspirate the air, and evacuate the fluid from the balloon. Clamp the tubing and position the balloon in the prevesical space. Route the tubing through the rectus fascia to the abdominal incision. Bulbous cuff placement. Place a 12F or 14F Foley catheter. Make a midline perineal incision. Identify the bulbocavenosus muscle. The bulbocavenosus muscle is either split in the midline or left intact according to surgeon preference. Use a combination of scissor dissection and a right angle clamp to dissect around the bulbar urethra under direct vision. Dissect out a 2 cm plane posteriorly around the urethra to accommodate the cuff. The most common site of urethral injury during artificial urinary sphincter placement is at the 12 o'clock position, where the urethra is adherent to the septum of the corpora cavernosa. Encircle a Penrose drain around the urethra and use it as a retractor to facilitate urethral dissection. Exchange the Penrose drain for a measuring tape. The urethral measuring tape is placed around the urethra at the site where the cuff is to be implanted. The measuring tape must fit snugly but without constricting the urethra. Remove the urethral catheter before measuring the urethra. Select the cuff size that corresponds to the measured length. The cuff is prepared for implantation by injecting the filling solution into the cuff, aspirating all of the air, and then evacuating the fluid from the cuff. Place the cuff around the urethra. Pass the cuff, tab first, under the urethra. Snap the cuff into place. Route the cuff tubing suprapubically through a subcutaneous tunnel to the abdominal incision. If it was divided, reproximate the bulbocavenosus muscle over the cuff followed by Colles fascia. Close the perineal incision. A transverse scrotal, single incision approach has been described, with results comparable to those of the classic two-incision approach. In this operation, the transversalis fascia is pierced to place the reservoir in the paravesical space. Alternatively, an approach through the inguinal ring has been described that does not pierce the fascia, but this approach poses a risk of iatrogenic hernia. Other authors have corroborated the success of this procedure. However, in a recent comparative study, Henry et al., 2008, found better overall continence rates and a lower risk of revision surgery with the classic perineal approach. Pressurizing the system. To pressurize the cuff tubing and the balloon tubing are temporarily connected with a straight connector. Remove the catheter. Flush the tubing ends to remove all debris. Fill the balloon with 22 ml of isoosmotic filling solution. Temporarily connect the cuff tubing and the balloon tubing by using a straight connector. This allows the cuff to pressurize. Wait 10 to 30 seconds. Clamp the cuff tubing and the balloon tubing with silicone shot hemostats and remove the connector. Remove the hemostat and aspirate all of the remaining fluid from the balloon. Refill it with 20 ml of filling solution. Clamp the tubing with silicone shot hemostat until the final connection is made. This two-step filling compensates for the potential pressure atrophy. Some surgeons feel that pressurizing the cuff and the balloon reservoir before making the final connection is optional rather than truly necessary. Many surgeons instead opt to fill the pressure reservoir with 23 ml of isotonic sodium chloride solution, i.e., 22 ml for the balloon and 1 ml for the cuff equals 23 ml total, and connect the tubing after all components, i.e., balloon, cuff, pump, have been implanted. By not pressurizing the cuff, the operation is simplified without compromising the efficacy of the sphincter function. Pump implantation. To implant the control pump in the scrotum, use blunt dissection to create a dependent subdartus pouch. The control pump should be placed on the patient's hand-dominant side. From the abdominal incision, dissect out the chosen hemiscrotum for pump placement. After filling the pump with filling solution, replace it in the scrotum. Place the pump in the most dependent part of the scrotal pouch, making sure that it is palpable and the locking button faces outward. The pump tubing should be above the rectus muscle and fascia in the abdominal incision. Connections: after the components are placed, trim the excess tubing. Connect the ends of the tubing by using the sutureless quick connectors. Suture tie connectors are used for revision surgeries. Connecting tubings should lie above the rectus fascia. Checking the device: after the connections, the sphincter is cycled. The device should be cycled 2 or 3 times to ensure good mechanical function. Adequate urethral coaptation may be evaluated via retrograde perfusion sphincterometry or flexible cystoscopy, but this is optional. After confirming that the sphincter is working properly, the cuff is locked in an open position, deactivated. To deactivate the device, the pump is squeezed and released several times to empty the cuff. When the cuff has refilled so that a slight dimple is palpable, the deactivation button is pushed to lock the cuff open. Be careful not to leave the pump completely empty, as this can greatly complicate activating the device later. During the healing process, the cuff must remain locked in an open position. The abdominal incision is closed. A small Foley catheter, 14F, is optional but recommended for the immediate postoperative period. Postoperative details. Intravenous antibiotics are continued until discharge. The Foley catheter is removed the day of or the day after the surgery according to surgeon preference. Postoperative antibiotics are prescribed at the surgeon's discretion. A study by Dropkin et al. Found that rates of explantation due to device infection or cuff erosion did not differ significantly between patients who received postoperative antibiotics after artificial urinary sphincter insertion and those who did not. Immediately after implantation, a 4 to 8 week deactivation period allows healing. The cuff is left open in a locked state. Postoperatively, the patient experiences no change in stress incontinence until the sphincter is activated. Thus, some protection must be used in the form of pads, external condom drainage, or intermittent catheterization during the healing phase. Intermittent catheterization is not a contraindication to an artificial urinary sphincter as long as the cuff remains deflated. Those with bladder neck cuff placement may perform self-catheterization without risk to the cuff and the underlying tissue. However, patients with bulbous urethral cuffs are at higher risk of injury from prolonged indwelling, rather than intermittent, catheterization.